Good morning. My name is Irfan Nooruddin. I'm the director of the South Asia Center at the Atlantic Council in Washington, D.C. And today is Monday, the 23rd of March, which is right now across the world seeing an epidemic, a pandemic of a once-in-a-generation pathogen of the novel coronavirus leading to the Covid-19 disease. All of a sudden, globally, a lot of us essentially become quasi-physicians as we try and decipher all the data that is coming out about everything from case fatality rates to infection rates and who's most vulnerable. But to sort through all of that, and in particular to think about the implications for South Asia, we are incredibly grateful this morning to have with us a new non-resident senior fellow of the South Asia Center, Dr. Edmond Fernandez, who is calling in from India to give us a perspective both about this disease, how it is likely to affect India, how it is already affecting India, and what he would advise governments around the world to be doing at this, depending on where they are in the pandemic. Dr. Fernandez is based in Mangalore in the south of India. He is a physician. He is the founder and director of the CHD Group, which specializes in community health. He has been an advisor to governments all over the world, but in particular in South Asia on emergency preparedness and disaster response, and so is uniquely qualified to help us understand this particular moment globally. Edmond, welcome.
Thank you, Irfan. It's a pleasure to interact with you and all the council members today, particularly at a time where humanitarian diplomacy is at its highest highs, and in terms of also global health challenges the world faces.
Edmond, thank you. Let's just start with the basic facts. To the best of your knowledge as of this evening, what is the situation in India right now? What are the number of cases and infections? What has been the main origin? Do we have community spread occurring in India as far as you can tell? And what is the basic testing capacity and regimen? For instance, thinking of the high density of population that still resides in semi-urban and rural areas, do we have the capacity to actually know just what the situation truly is?
So right now, as we speak today, this morning, it's evening in India. This morning, the Ministry of Health website said 415 positive cases. And just a while ago, when I was referring the ministry site again, it says 402 cases, which is interesting enough. If you had cases which were discharged, you should have technically shifted and increased the numbers. But now the question is, are the tests going into false negative or false positive? Are we detecting positive cases and then it's suddenly on retest saying negative? That's a bone of contention as well. But in terms of community spread, I think the Indian government has realized it just on time that a lockdown is necessary for survival. Otherwise, a tiny virus is going to force a lockdown in the next 1 month. So India, in that perspective, has been very lucky because you had China being affected, then you had Iran, you had South Korea. So we had reasonable buy-in time to understand the methodology of the virus, to understand what are the containment measures, to understand what are the chances of how things would get worse. Yes, our health systems isn't all great, and the world knows about that fact. There's nothing to talk about that. But at the same time, how do we really protect our citizens in a complex 1.2 billion nation? And this is the litmus test to our health system. This is a litmus test to policymakers and also a litmus test to the government itself.
Given that litmus test analogy, are we really prepared? Do hospitals have the emergency room capacity, whether it's hospital beds, staff, personal protective equipment, the supply chains for ventilators and masks. These are all things that are apparently under great strain, even in the richest, most developed country in the world, here in the United States. From your perspective, are the hospitals and public health centers the front lines for health workers getting the support? Do they have the equipment that they're going to need as this gets worse?
Simply put in one word, the answer is no. Yes, the need for increasing diagnostic tests is imminent. What we are proposing to not just national governments, but also state governments and district level administrators is to contain this or even to mitigate it as a preparedness measure. We need to make COVID exclusive wards, and if not, if achievable, COVID exclusive hospitals. Right now, in a state like Karnataka, uh, Bangalore has declared that they've converted Victoria Hospital into a 1,500 bedded exclusive COVID hospital as a preparedness. Question is, even a tier 2 city like Bangalore has positive cases for COVID now. What is our methodology other than social distancing and lockdown? We will need to do more than that. Additionally, what the government could have done going 2 steps ahead by not bringing in authoritarian egoism is to engage proven track record civil society organizations to spread authentic messages, because every NGO working in different sectors has a sizable chunk of database which could have pushed genuine authentic communication to the masses and leading to decrease in panic. I mean, what intrigues me the most is people are still trying to understand, where can I get masks? What type of masks do I need? But in reality, you really do not need masks. And every time somebody just coughs, possibly because of a normal seasonal change or viral infection, people look at them with suspicion. Hey, are you coronavirus? So this isn't really the best of times, but at the same time, a little bit of grandmother's common sense could have done things a lot more better for India. I mean, with God's grace, we are still at 415 compared to other nations. But if you look at the Lombardy data and extract it and multiply it with our population numbers, Karnataka would probably see around 80,000 cases in Bangalore alone, of which more than 2,000 to 3,000 would need ventilator care moving forward. So this isn't the most ideal numbers. And then leave alone tier 2 cities, tier 3 cities, rural areas, we're not even getting there. As far as coming back to your question of personal protective equipments are concerned, healthcare providers, yes, they need to use a respirator mask N95. If the status of the patient is known, then depending on the kind of intervention, surgical gowns, suits, gloves is encouraged. But on a normal course, there is a shortage of mask, surgical mask itself, leave alone N95. And in primary health centers, in rural areas, doctors don't even use masks. So it also leads to the point that probably we are uh, moving forward, buying time. I mean, India is also a religiously woven country, so hopefully the gods intervene with the juncture at which we are.
Yes, religiously woven, and we have a lot of gods, so hopefully all of them are on our side. Can I ask you a question? You raised in your last response this issue of behavioral change communication, of getting the right information out. The World Health Organization has described this pandemic also as an infodemic. And our colleagues at the Atlantic Council, in a variety of settings, including the Digital Forensics Research Lab, have been documenting the spread of misinformation about this. India is one of the ground zeros for misinformation coming through WhatsApp and other sorts of things. And even yesterday, on Sunday, the 22nd of March, at the Prime Minister's request, there was a voluntary Janta curfew. At the end of the day, there was at 5 p.m., the scene of Indians in masses banging, making noise, talis, is sort of one sense, an incredible demonstration of togetherness, of solidarity, of community spirit. But at the same time, for a lot of observers, scenes of large throngs of people out in the streets together, sort of shoulder to shoulder, seemed like the basic message about social distancing had yet to be understood and accepted. Can you tell us a little bit about, not just right now, but your research and your work on what are the most effective ways of communicating these complex ideas about health and public health to average citizens, many of whom might be still, limited in their literacy, might not have very high levels of education, etc.
So our experience as a grassroots level service provider organization, particularly working with the UN and the government, has been that behavior change can easily be broadened only by creating fear. For example, we were working to reduce the burden of severe acute malnutrition in under 5 children in 6 districts of India, what in US you would call counties. So what we tried to do is when we told the mother that, you know what, your child is severely malnourished, which means your child would be compromised in terms of immunity, your child would probably have low intellect and growth would possibly be less compared to children of, other children of the same age. The mothers really did not want to get their child treated for malnutrition or even admit the child into a nutritional rehabilitation center. And the beauty of a nutritional rehabilitation center is that the government pays the mother. Even just for staying 14 days, she's paid every day. She's given free food. The child is given free food. Medicine treatment is free. And in spite of that, they refuse to stay. So then moving it 2 levels up, what we had to do is we had to tell the mother, you know what, if your child continues like this, the child is possibly going to die in some months. And that is when, as a mother, you have the real emotion coming out like, oh my God, are you serious? And this panic or fear is a motivation for behavior change. I recognize as a healthcare provider, it isn't the best of options, but you also need to weigh India in terms of literacy levels and in terms of also education and schooling, because education and schooling are not the same. And unfortunately, this has really worked in our favor, saying that, okay, if your child is going to die, you need to provide immediate solutions, and this is what you have to do. That has brought in behavior change. Coming back to extrapolating some of that into how an Indian setting is, like just this morning, I got a message saying that, okay, doctor, you've been doing a lot of things in natural disasters, do something here. I think otherwise we can probably relax. It isn't that bad, but that's what people are saying. So I said, okay, if you say it isn't that bad, then just prepare more coffins, prepare more burial grounds, and we can just dispose of people like mosquitoes. And then the person immediately comes with, oh my God, that's scary. So this kind of, and this is a person who's a master's degree qualified person. So you take it for granted that, okay, health issues can wait. India, since historically, like since 1947, we have never won elections based on the healthcare agenda. So healthcare has never been a priority for politicians and also for vote banks. So you can imagine even a virus of this nature, until it paralyzes your daily life, saying that, okay, you can't go to work, you can't travel anywhere, you can't go to the restaurant, you can't do anything. That is when you will start to accept the fact of ownership in healthcare. And community ownership in healthcare can only be built this way in a country as diverse, as complicated, and as uh, intellectually mixed like ours.
That's a fascinating point, and it really illustrates the difficulty that lots of people, myself included, I suspect, have at really understanding risk, right, and assessing risk. I know you consult and talk to lots of governments all over the world, including, of course, the Indian government. Do you think that the Indian government, the actors you've spoken to, have fully grasped the risk associated with COVID-19?
I don't think so. I mean, luckily this time around we have the health minister who is a qualified person as a healthcare provider. But otherwise, if you look at our bureaucracy, they are not essentially from healthcare backgrounds. And of course, bureaucracy and civil service has a special kind of egoism. And the tendency to not listen to others definitely exists.
Okay.
In terms of that, I think drawing examples, bringing in emotional conversations, more in terms of stories and narratives, is the way um, attention could be caught. This reminds me of a book called Smart Patients, Safe Hospitals by Peter Pronovost. And this was a study done at Johns Hopkins many years ago, where he tried to understand how do you communicate to the doctors at Johns Hopkins who consider themselves the best in the world or probably equivalent to God, to tell them that they do mistakes and patients are dying because of preventable errors. I mean, this is a population which can access statistics and data on their fingertips. So, what do we do next? The only solution was call the patient's relatives who have lost their near and dear ones. Tell them to communicate straight the story of what it means to have grief or loss in your own life. And this is the only thing that can move a cold hearted robotic doctor, or likewise a cold hearted robotic red tapeism driven bureaucracy.
That's fascinating. I mean, so it actually might imply that the more we hear about aggregate numbers, hundreds of thousands, 200,000, that, well, as important as that is less effective from behavior change than those individual stories of somebody's grandmother dying or somebody's child, God forbid, dying. The human touch is critical in communicating this. I want to ask you a couple of other questions while we have you. The first is, we're learning a lot more, as I understand, about which populations are most vulnerable to to COVID-19, in particular in terms of fatality. And what we're seeing, I think, out of Lombardy is that older people in particular seem to be more susceptible. As I understand it, the initial research from China and Italy suggests that people with smoking histories and pre-existing health conditions are more vulnerable. In India, there's a well-documented, especially in the north of India, well-documented pollution crisis that has led to emphysema and other non-communicable diseases related to pollution going up. Does that make India more vulnerable to COVID-19, or does the fact that India, for the most part, is a younger population potentially mean that there should be fewer hospitalizations, fewer deaths associated with the disease?
No, I think in terms of pollution levels, to link pollution with COVID-19 would be very premature, as there is very limited body of evidence to say that, okay, pollution levels have triggered death in patients who've died. But nevertheless, what we need to understand is that living over the years in a over polluted city would definitely leave long-standing respiratory issues. But in terms of the virus is directly connected with comorbid health conditions, wherein the immunity level of the body to fight the virus gets compromised. And this is where we would lose elderly patients, particularly those who are having cardiac ailments mixed with diabetes, mixed with other respiratory issues like long-standing chronic obstructive pulmonary disease, or even chronic bronchitis. So this is where you would end up eventually putting them on ventilator because of breathing difficulty, and then you lose the fight to the virus. But otherwise, in terms of air pollution, although it is an issue, in terms of COVID, I don't think it would go anywhere and anytime soon.
Okay. If you could advise the government, whether this is the government of Mangalore, of Karnataka, of India, as to what they should be doing today, what would that advice be? How severe lockdown needs to be implemented in your opinion, or does India have time yet, given the economic consequences of a lockdown? Should they be waiting, or is the time to act right now?
No, I think India has already missed the bus. The lockdown should have happened 2 weeks ago. Now we also have imported cases from Indian nationals and also had foreign nationals carrying the virus, which of course can still be contained given the lockdown measures now implemented. But let's understand the fact that we need 14 days of lockdown. The Janta curfew of 1 day voluntary is not going to help. Yes, in terms of governance, India has invoked the Epidemic Act, invoked the Disaster Management Act. Rules are being cited, sweeping powers have been given to bureaucrats. The question that concerns me the most is there is a leakage in all of this, which does not seem to have been plugged. Very recently, Karnataka formed the state task force, and I'm sure other states also have formed task force of similar nature. But this should have ideally been formed at a district level. And the district level task force should have involved community health physicians, public health professionals, infectious disease experts, not for heaven's sake IAS officers. How do you form task force with IAS officers who are going to quote rule books? I mean, it's not going to really work. You need to listen to doctors at this time. And the Indian government has done sizably well, but it could have been better than this had they involved NGOs, which has been my major source of advice. Have been trying to advocate for this, float this around, engage NGOs in advocacy, in risk communication, in preventive strategies, in behavior change strategies. This could itself have snowballing effect among the populations. Rather, what is happening now is every person is taking a selfie like this, shooting some kind of video, and then pushing it into WhatsApp groups that gets forwarded. Our rural folks are waiting every day saying that, okay, video aane do, like let a video come. And people just end up watching all kinds of video, and you don't know what is authentic now. Additionally, the health minister could have gone every evening on record addressing the press of the country saying that, okay, this is the situation report. That would have been an ideal situation. But nevertheless, participating, networking, and collaborating with organizations who have worked with the ministry before, who have worked and networked with the UN should have also been cast into. Mind you, India is a very rich, resourceful country in terms of human resource, may not be in terms of doctor patient ratio, but in terms of intellectual capital, in terms of human resource. Why are we not cashing into all of this?
That's a fundamentally crucial question. You have written elsewhere that this pandemic is likely to change the face of global public health. Could you expand on that idea? You already previewed some of this, but what changes do you think will occur because of what lessons we end up learning, maybe the hard way, from COVID-19?
I mean, it takes me back some years ago with my conversations with the US State Department officials, where I floated this idea saying that every embassy around the world should probably have a global health expert in the missions. Because you look at health, which is demonstrated live through SARS, through MERS, through coronavirus, or you also look at natural disasters, which is transboundary in nature. So this does not mitigate any country or any official saying that, okay, our country can do it all. No. So having global health experts or having informed councils part of the embassies would work to strengthen humanitarian diplomacy around the world, across Asia as well. And it would really work in favor of policymakers shaping their agendas through informed risk planning. As far as how this is going to change the way global health works, is you have companies working in artificial intelligence who are now looking at healthcare intelligence. You have remote monitoring, you have video consultations, you have even reports being dispatched on official WhatsApp groups created. And now this is becoming a new normal as a way of life. This is definitely even going to change the way schooling works in terms of global health. I mean, put some years ago, governments would never even consider the fact that, okay, e-learning, what is that? Kindly report to university or to college. But today, if you're going to survive for the next 2 or 3 months through e-learning, e-exams, and then you have reasonable amount of time to even spend with your family, although the size of the family is getting smaller and smaller, and also the definition of family is fast changing. This would really work in favor of the human race, which has lost, or probably in a more polite terms, guided missiles and misguided men. It would bring us back to the days when appreciating life in terms of nature, in terms of rosy sunsets, picnics by the waters, chirping of birds, the best things in life was free. Maybe it would take us back again to those times. I pray.
That is a perfectly optimistic note. It is ironic that it has taken this for us to realize how much we need and rely on social contact, how many of the friendships and acquaintances we take for granted we now miss because we can't see them, and how we have to find pleasure in those simple things, the walk around the neighborhood, time spent with one's family. And so maybe that is the silver lining. Edmond, we know that you are going to be on the front, you are on the front lines of this, both as a physician, as a healthcare provider, but also as a public intellectual advising India's government and other governments. And so we are incredibly honored and grateful for your role as a non-resident senior fellow with the Atlantic Council. We hope you'll come back again very quickly so that you can give us an update on where things are at. And we wish you the very best of luck.
Thank you so much for your time. Have a nice evening ahead.
Thank you.